Okay, part 2, shock, chapter 12, EMT class, the progression of shock. So you see, you've got a couple different stages of shock and the progression of it. So we go from compensated to decompensated and then to irreversible shock. Irreversible is where we want to really stay away from. If we're able to not get the decompensated, that's really good as well. It's even better, but we definitely want to stay away from irreversible, because once again it is irreversible. So the one thing that is easy to notice between these guys is when we go from regular compensation to compensated shock, you'll notice that the cardiac output is about the same, but the heart's having to work a whole lot harder at it. So meaning having to pump harder or pump faster or both, and to maintain those same numbers. So blood pressure may be the last measurable factor change in shock. So when you see a drop in blood pressure and it's become evident to you that there is one, shock is pretty well developed. Now this is particularly true in infants and children. Infants and children can maintain their blood pressure until they have blood loss that is more than half of their body volume or their blood volume. So that's a real big deal, and you'll hear it over and over when we talk about kids, is that they compensate and compensate and compensate, but when they're done, they're done. It's almost like a little cliff, and they're just going right along, and then phoom, they just go straight down. So remember, those kids, they have a pretty vigorous compensatory system, but when it's done, it's done. So by the time blood pressure drops in this population, meaning infants and children, they're probably pretty close to death. So we can expect shock in a lot of emergency medical situations, whether it's trauma or a medical call or whatever. Also expect shock if a patient has any one of the following conditions. So severe fractures, abdominal or chest injury, spinal injury, severe infection, major heart attack, anaphylaxis. They all have ways that a person can get into shock from these type of complaints. So let's get to it. What does this look like? Scene size up, not a lot changing. In incidents involving violence, we want to make sure that the police are on scene. We want to look for clues as to mechanism of injury or nature of illness. Move on to our primary assessment. So one of the first things we're going to do with these patients for suspected shock would be we want to determine their level of consciousness. So we're going to talk to them and figure out whether they're alert or verbal or they respond to pain, whatever. Also going to identify and manage life-threatening concerns as they are found. So, we want to look for airway issues. We definitely, if we're talking about shock, we definitely want to look for bleeding issues. Make sure we're not, a person's bleeding out, has a bunch of gross bleeding. So, and then we want to determine the priority of the patient and the transport. So, transport the patient. So we want to see whether are they sick or not sick, and then we want to get going if they are. So a patient with a massive hemorrhage, now these guys can require a tourniquet or direct pressure dressings when tourniquets aren't feasible or even available before the airway is opened. So typically, we've talked about it's A, B's, and C's, except in trauma, it's C, A, and B. We want to make sure that we're addressing circulatory issues right away, because people can bleed out really quick. So if the patient has life-threatening external bleeding, it should be addressed first. Now we say first even before A and even before B. And up until recent times, it's A, B, C's no matter what. And a lot of that has changed. So ABCs then can be assessed and treated, and then treatments for shock provided. Want to make sure we're getting lots of high flow O2 to these guys. Make sure we're helping in the perfusion of these damaged tissues. If the patient has signs of hypoperfusion, we want to treat aggressively, provide rapid transport to the hospital, and then request ALS, so advanced life support, as necessary to assist with more aggressive shock management, because there's not a lot we can do on these days, right? As an EMT, we don't have a lot of tools and tricks up our sleeve. Our biggest thing is that we recognize they're sick or not sick, and not screw around and make sure we get them to the right place. Now we're going to form that general impression. We're going to look at airway and breathing. So we want to make sure the airway is patent. We want to quickly assess breathing. We want to look into circulation. We want to assess the patient's circulatory status, looking for shock and all of that, because they can reveal some important clues regarding the presence of shock. Check for a distal pulse. If there is none, check for a central pulse. Determine if the pulse is fast or slow or weak or strong or, just altogether absent. A rapid pulse suggests compensated shock because the heart's having to beat faster and faster to still equal that same cardiac output. So in shock or compensated shock, the skin can be cool and clammy and ashen. Remember, we talked about the shunting. We talked about certain sphincters closing down and keeping blood in certain areas and letting it go to others. Well, remember, we mentioned the skin. So that's why we might see that the skin is cool and clammy or even ashen. If they have no pulse and is not breathing, then we want to start CPR right away on those folks. And then transport decision. We want to identify any life-threatening bleeding in trauma patients. So if we do discover some of that, we do see some serious bleeding, we want to treat it at once. Now you can also assess the skin temperature, condition, color, check for capillary refill time, determine whether the patient should be treated as a high priority or whether ALS is needed and which facility to transport to. Now, trauma patients with shock or even a suspicious mechanism of injury, generally these guys should go to a trauma center if you have that available. History taking. So after life threats have been managed, we want to get in there and determine the chief complaint, and then we want to hit our sample. So remember, we've talked about our EMT acronyms. Sample is one of those. So you want to start filling in all your letters there. Secondary assessment begins. We want to repeat the primary assessment followed by a focus assessment, and then perform a secondary assessment of the entire body if your patient is a trauma patient with significant mechanism of injury or multiple injuries. So remember, we're always looking for things that have changed or maybe things that we missed. Your patient's a trauma patient with significant mechanism of injury or multiple injuries, then we want to perform a secondary assessment of the entire body. If our patient gives you a poor initial general impression, we want to keep looking. We want to perform that secondary assessment. If you found problems in the primary assessment, then of course your patient has a medical problem but is not responsive. Lots and lots of things. We're trying to find out things on the secondary assessment that either we missed or that are changing or whatever. So we're going to reassess the patient. The vital signs, the interventions, chief complaint, make sure has things gotten worse, has things gotten better. Determine what interventions are needed for your patient based on the assessment findings. So we want to focus on supporting the cardiovascular system here. We want to treat for shock early and aggressively by giving them O2 and keeping them warm. We want to follow standard precautions, of course, control all obvious bleeding, and then we want to make sure that they have a good airway. And as well, maintain manual inline stabilization, check for breathing and pulse. Now, if we're able to, we want to try to comfort and calm and reassure the patient, but at the end of the day, we still have to take care of them and do a good job of getting them to the right place. Don't let them eat and drink and all of that, and all that stuff. This isn't a no smoking and a no snacks flight that we're going to be taking. So, as soon as you recognize shock, we want to begin treatment. We want to, once we recognize that, we want to move on. Place blankets under and over the patient. Want to keep them warm. Consider the need for ALS. We definitely want every 5 minutes. We're going to start looking for those vitals. Now, looking at different kinds of shock. What are we going to do for cardiogenic shock? So that was that pump problem, right? The heart cannot pump blood throughout the circulatory system. So the patient who's in shock as a result of a heart attack does not have the power to pump blood throughout the circulatory system. So they have decreased cardiac output, what we've talked about. And usually, patients with cardiogenic shock don't necessarily have an injury. They could be having chest pain. They could have decreased cardiac output secondary to maybe to a myocardial infarction or something, to a heart attack. Now, these patients should not receive nitro. By definition, they will be hypotensive. If they're not hypotensive, maybe they're not in shock, because what makes you think they're in shock unless they're hypotensive? Signs and symptoms, when we look for that, place the patient in a position that eases breathing as you give them high flow O2, so a good position of comfort. Prompt transport. If ALS is not on scene, you want to think about maybe a rendezvous with them. So you're calling up to see if another system, and you could meet someone somewhere, another truck that has an ALS, a paramedic on there or somebody. Treating obstructive, so for cardiac tamponade, remember we talked about the cordial sac having being full with fluid and pushing on the heart, so decreasing cardiac output. So increasing cardiac output is going to be our priority, but how do we do that? Well, we can't do that. So we've got to recognize that that's what it is and apply high flow O2, and then recognize surgery is the only definitive treatment for this, and we've got to get them to the right place. Tension pneumo, breathing issues, whenever you have no lung sounds essentially on one or maybe even both sides. Apply high flow O2 to prevent hypoxia. Chest decompression is required. You need ALS assistance on this call, so you need to try to get ALS there or to rendezvous with them. Now, septic shock. Septic shock requires a lot of different things. There's a lot of different medications and things that people use and may need in a septic shock patient. Once again, the major thing is that you recognize that this patient is in septic shock. So the proper treatment of septic shock requires complex hospital management, including typically quite a few rounds of some antibiotics. So you definitely want to use your standard precautions, transport promptly, O2, support ventilations as needed. You want to preserve their body heat. And then maybe where you're at or the hospital you're going to, they want you to call in a code sepsis or alert the sepsis team if that's available. This is someone who they may have a fever. So you can have a hot and a cold septic shock. You know what the hot one is the body fighting the infection, and it's generating all that heat. Well, the cold one is the body's been fighting the infection and is now essentially kind of given up that mechanism. It's requiring too much energy and kind of giving up that mechanism of creating that heat. Now, neurogenic shock. So we want to make sure that we're still have a good airway, spinal immobilization, because this is the one that has maybe a spinal injury. Want to assist that inadequate breathing is needed, conserving body heat. Some of that really mostly the same things, except these probably are going to need to be on a board, on a backboard. Treating anaphylactic shock. So really the only effective treatment for a severe acute allergic reaction is going to be to administer epinephrine by the way of an intramuscular injection. So you giving or either assisting or giving a epinephrine shot. So a patient with anaphylaxis requires immediate transport. Additional emergency care includes high flow O2, assist ventilations if needed. Try to find out what the agent was that caused the reaction. And remember, these things can get worse suddenly, or it can be a little bit over time. So these are a good idea to look for some ALS backup as well. So psychogenic shock, this has to do more with fainting and that type of thing. Someone faints and they have their vessels kind of enlarge and the pipes get a little bit big, and so we lose pressure. So in an uncomplicated case of fainting, once the patient collapses and becomes supine, circulation of the brain is typically going to be restored. So these things can worsen other types of shock because, once again, those pipes dilated and we don't have the pressure that we need. We do want to look for some further injuries, though, if they did fall. If a patient reports not being able to walk after a fall, thought to be related to psychogenic shock, you should suspect another problem. So maybe they have a head injury, maybe they hit their head or they hit their back or something. Transport these people properly, make sure you get them to the ER. Hypovolemic shock. Biggest thing we can do for this, control all obvious external bleeding. We definitely want to keep them warm and keep this patient nice and warm, covered up with blankets. Recognize internal bleeding and provide aggressive general support. So airway, O2 when needed, rapid transport, right person to the right place, that type of stuff that we've been talking about. Now, treating respiratory insufficiency. Immediately secure and maintain our airway, getting into our A, B's, and C's, right? We want to make sure that we clear everything out, clear the mouth and throat of any obstructions. That can be anything from mucus, vomit, foreign material, all that kinds of stuff. Provide some ventilation if necessary. Go ahead and put them on O2 if necessary. Make sure you transport the patient promptly. Now, older patients, we can have some problems with shock because of their body doesn't quite bounce back the way it needs to and all of that. So they usually have a little more serious complications than younger patients. Although illness is a common complaint among older patients, understand it's not just a part of aging. So a lot of these older patients take numerous meds that can either mask or mimic signs and symptoms of shock. So, normally where their heart rate would speed up to start compensating for the shock that they might be in, they may or may not be in. They're taking a medication, say they're taking a beta blocker, which slows their heart rate down, and now their heart will not be able to speed up because it's being pharmaceutically controlled. So you get a lot of weird things going on, that we need to just understand that this person's sick and we need to get them to the right place at the right time. Want to make sure you're controlling life-threatening hemorrhage and suction and O2 and all the same things that we've been doing. Make sure you keep them warm. This is a really important thing. And then provide rapid transportation. That's it, part 2 of chapter 12, shock. So we'll see you next time.